Okay, I'm back with Dr. Michael Lewis. Dr. Lewis is the Director of Foundation Endodontics in Teaneck, New Jersey, as well as faculty at the Hackensack University Medical Center. Michael, thanks again for joining me and doing these cases with me. Let's go to the next case here. This is an interesting case, again, with some external cervical root resorption, which I would let you go ahead and describe to our viewers now.
Sure. So this was a 77-year-old male patient. He actually happened to be the father of one of my referring doctors. And I got a call on Thanksgiving weekend.
No pressure.
No pressure at all, right? I got a call on Thanksgiving weekend. Mike, my dad's having a swelling and pain. Would you be able to come in and see him? So came in, and this case was definitely an external cervical root resorption. We know that when we took some multiple angles, the lesion was moving. It was not in the center. And when we took a closer look, there was probing to the apex of the tooth. And you could see here these two images, that 16-millimeter probings going all the way down to the end of the tooth. And I had a debate. All right, we got a cervical resorption case. Well, how am I going to approach this? Am I going to approach this surgically, lay a flap, and clean out the lesion from externally, and then go ahead with the endo, or am I going to see if I can manage this non-surgically? Given how guarded the prognosis on this case was, and given the patient was not going to be around for the next week or two because he was leaving back down to Florida, that was the other part of this case. He was going down to Florida in the next day or two. I really did not want to go in surgically here, so I said, let's go in, let's access the tooth, let's do the endo, and let's see what's going on. And we opened up the tooth, and we were able to clean. Let me just take you through the images here from the cone beam CT first. That probably would make a little more sense. You can see here this lesion extending to the buccal, and here we could see it in multiple dimensions. Pretty significant lesion. I felt like I could actually gain some access to this lesion and clean it out non-surgically. So that's what we elected to do. We opened up the tooth, and first we just cleaned and shaped the main canal initially. Took that down to 4506, and we obturated with VC sealer, and I burned out the cone to about 1 millimeter or 2 below the orifice of that cervical resorption lesion. And then I went about cleaning and shaping that, I wouldn't call it cleaning and shaping, let's call it debriding that cervical lesion with long shank Mueller burrs put out by Brasler. I used the green and the blue shank burrs. And I was able to get that lesion cleaned out pretty well, certainly at the base. And just lifting up the burr a little bit, was able to scrape away the coronal surface of that lesion as well. And what we did at that point was we obturated the apical portion with a cone, burned it off, and then we put down some sealer, some BCRM putty into the lesion and compressed it. Actually, at this point, what I was doing was I took a cotton roll and wedged it against the gingiva, creating almost like a matrix that I could compress the RM putty against and prevent it from extruding into the sulcus. And that seemed to work out pretty well. I was pretty happy with the result, and thankfully, I was able to spare the patient any need for surgery. Given his travel plans, I was really uncomfortable with having him go down to Florida at that point with some stitching and all that. Patient is going to be coming back in July for a post-op, but in the meantime, he was kind enough to send me a photo of what the tooth looked like today. And this tissue looks a heck of a lot better than it did when he came to see me. That canine there looks even better than the premolar behind it. But that's the long and short of the case. I'm happy to answer any questions you might have had.
Well, that's wonderful. I think you managed that beautifully and very conservatively. And Michael, a lot of people would be raising a flap and doing the surgery right away. A lot of times I have planned to treat these, given the size of the lesion, the cervical region, and the fact that the CBCT shows that it is into the pulp, you do need to do the non-surgical treatment anyway, whether the cause of this large sinus tract here was just a gingival abscess or an endo-perio problem is kind of immaterial at this point. You need to do the endo prior to the repair of the lesion anyway. And a lot of times in the past, we all used to do these things surgically, repair them following the non-surgical treatment. But I tell you, I've done a few of these too, and I find I have had the patients come in for the surgical appointment, and I'm like, well, maybe we could just postpone the surgery because I don't feel like it needs the surgery at this point. They do heal very nicely when you have done a good job cleaning it, as you have in this case. You managed to clean the lesion completely internally using burrs. Any other tips or tricks for cleaning that area? Do you ever cauterize? Do you use any trichloroacetic acid, any of those chemicals? What is your irrigation protocol in cases like this?
Oh, my irrigation protocol is basically sodium hypochlorite full strength and EDTA alternating. And what I'll typically do is just a lot of manual dynamic irrigation. In this case, because I was concerned that I wasn't really touching every aspect of that lesion with the burr, I really used a lot of manual dynamic irrigation where we're taking the master cone, pumping it up and down, 25, 30, 50 times, just getting that lesion really cleaned out. That was the extent of the protocol. Afterwards, we just went ahead and you put the BCRM putty in after the final wash of EDTA and sodium hypochlorite.
Well, that's terrific. Michael, are you ever concerned in cases like this where you have a communicating lesion with the external surfaces to use an irrigant such as sodium hypochlorite in fear of a potential hypochlorite accident or something like that?
I hear that concern a lot. In general, if you're not injecting under pressure, I have not had any mishaps with it. We're just making sure that you're using side-vented needles and making sure it's not binding. I've never really had an issue. I've done lots of cases, never really had an issue with it. I see those concerns reported in the literature, but thankfully I've not had to deal with it.
I think the trick, as you mentioned yourself, is passive irrigation. A lot of times in cases that have had perforations, people don't realize that they're perforated. They actually put the needle into the perforation site and they inject outside, clearly causing external injection of lots of hypochlorite into the tissues. So thank you again so much for this case that you shared with our viewers, and we'll come back and do one more case.
Thank you.